faculty meeting, September 1, is presented by Dr. Emma Gilani. The topic is not new, but it's a new world. Management of neuropathic pain, that we have so many neuropathic patients in our pain population. I'm so glad that Dr. Emma Gilani is going to give us a talk. He is an associate professor at McMaster University in the Department of Neurology. He's been with us for 15 years and actually was with us in the pain clinic at the beginning and then for about 4 or 5 years. His expertise is, again, in neuropathic pain. He did tons of research in neuropathic pain. He is still doing research on, particularly on neuropathic pain secondary to chemotherapy. And also he's got a lot of fellowships. I don't know if I can remember them. Fellowship of EMG, nerve conduction, pain fellowship, and I'm missing a few more. Neuromuscular, it's just too many lists. So without further ado, and also I'd like to welcome the participants through WebEx as well. Actually, I'm seeing here there were 4 or 5 people. So I'd like to welcome you as well. And at the end of talk, we'll open to questions, and Dr. Emma Gilani is going to answer all the questions as much as he can. So at this point, I'd like to welcome Dr. Emma Gilani to give us a talk on management of neuropathic pain.
Thank you, Joe. It's good to be back to the pain community. I have nothing to disclose, and what I wanted to talk about is really just a basic overview of neuropathic pain, and more in particular of the peripheral sources of neuropathic pain, approach to management, and discuss some of the guidelines from different parts, from Europe, from Canada, and from US, not guidelines, it's a review by one of the authors, and majority of the neurology community at least follows those. And then a bit of approach to patients who do not respond to the medication that we use for neuropathic pain through these guidelines, and maybe a little bit of discussion at best to see maybe we're missing a boat and future may hold things a bit more differently than our approach right now. What is neuropathic pain? It's the pain that's arising as a direct consequence of lesion or disease affecting the somatosensory system. Previously, we used to use it from sensory only, and this is more in relatively recent. It's been a few years since the IASP changed the definition. If the source of pain, neuropathic pain, is from central nervous system, it would be central neuropathic pain, and if it is peripheral, then it's peripheral neuropathic pain. So we'll talk a bit more detail about peripheral source. Maybe I'm biased as most of my patients belong to this group. Central neuropathic pain, most of us would be aware, would be post-stroke central neuropathic pain, pain related to spinal cord injury, pain related to multiple sclerosis. Approach is a little bit different if you go by the evidence available to us. And the peripheral neuropathic pain can come from many different sources. So neuropathic pain by itself represents not one entity, not one disease process. It is a syndrome. It's specific symptoms that you hear from in history, and you're able to elicit different signs to make the diagnosis. But it is caused by different disease processes. And the main challenge, and I can give you a simple example. This morning I had a patient in my EMG clinic. She came from cancer center. She had ovarian cancer, was treated with platin and taxane-based drugs. Platin causes neuronopathy or ganglionopathy, and she had significant pain related to it. Worst pain was in hands. And what I've seen over the last 4 to 5 years is that the majority of the patients who get platinum-induced neuropathy develop carpal tunnel syndrome. So what happened is that it was not letting her sleep. The pain was really bad in intensity, frequently waking her up through the day in hands. And what was the answer? Hydromorphone. Hydromorphone at 18 milligrams BID, and then she's about more than between 12 to 16 milligrams, just a quick release Dilaudid. And that was not the answer because carpal tunnel approach to treating it is different. So many times the biggest challenge as in the primary care setting as well as when we get a patient in tertiary care setting is establish that primary diagnosis. And I think if we put neuropathic pain as one process, we're not doing justice. Many times if you're able to make that underlying disease process diagnosis, your approach to management would change. So as an example, you get a patient with peripheral polyneuropathy. As a neurologist, my challenge would be there are so many causes of neuropathy. It can be toxic, anywhere from alcohol to stuff that patients are exposed to at the cancer center or at the type of work or other poisons that they may be predisposed to. It could be immune-based process. It could be something they were born with. It could be, it's a very busy slide, but the point I'm trying to make here is really that as a physician, you have to go, okay, this is a peripheral polyneuropathy. Where is it coming from? If this neuropathy is, say, coming from diabetes, and diabetics get many different types of neuropathy. It's not only the distal sensory or sensory motor. You can get treatment-induced neuropathy or called insulin neuritis. You can get inflammatory plexitis or diabetic hemopathy. You can get polyradiculopathy, thoracolumbar, and they're very painful conditions. But treatment approach is different. You can give them supportive treatment, but at the same time, if you're able to make the diagnosis well in time, you may be treating them with steroids more than treating them with just the painkillers. So that's the challenge that most of us face, but we have to take the history and physical examination, direct it and investigate it as much as we can to establish the underlying disease process causing that neuropathic pain. So neuropathic pain can be acute or chronic. So that's controversial. Some people generally accepted chronic is 6 months or more, but there is enough group that will say with 3 months or more for duration of the neuropathic pain. So the commonest peripheral neuropathy that we encounter is symmetric and distal predominant. Okay. So you can have distal sensory and autonomic symptoms and chronic ones, or you can have sensory motor and plus minus autonomic symptoms. Acute neuropathies that happen in diabetics, as I mentioned, insulin neuritis would be one, or you can have the diabetic hemopathy. And say insulin neuritis, which you see maybe one case every year or 2 years, you get mainly, when we do the examination, they only have small fiber modalities involved. There is no involvement of the large fibers, so the vibration and joint position station is normal. You see that there's pinprick reduction, temperature reduction, and the ankle joints are preserved. And those people, the neuropathy happens soon after you have a better control of sugars, sometimes by losing weight and bringing sugar from 10, 12, 14 down to close to 6. And that's when they develop the severe neuropathic pain. And in that case, yes, supportive treatment is important, but reassuring the patient that within a year, if we continue with good sugar control, these symptoms will go away. And usually by 6 to 7 months, they spontaneously improve. So just making the diagnosis is helpful. So I'm just giving a bit of the diabetic patients. So lumbosacral radiculopathies, usually there is about 60-pound weight loss, and they present like classic symptoms of, electric jolt-like feeling, jabbing, stabbing pain. Usually it's dramatic picture. You lose about 60% because you lose muscle mass, and it can affect the lumbosacral plexus, multiple lumbar, and multiple thoracic nerve roots. And in those cases, trying pulse steroids up to 1 gram a day, once a week for 10 to 12 weeks is the ideal treatment because that helps the pain the most. And then you have other sources, but this is the only reason I'm bringing these slides up is that when we try to clump everything under, there's an approach where you say, okay, you have this questionnaire, you have that questionnaire, this is neuropathic pain or non-neuropathic pain. And I think we have to think beyond that. We have to make that diagnosis of neuropathic disease, okay, this is because your peroneal nerve is affected. This is because this nerve was cut, right? So in my patient group, about 39% of the patients who have mastectomy can get the post-mastectomy pain because the dorsal branch of the first intercostal is affected, right? And so making that concrete diagnosis, if you're able to establish it, you can bet that the management will go more smoother than when you're running into more and more challenges when the diagnosis is not clear. I keep pressing the other point. So when we look at patients with neuropathic pain, what kind of symptoms do they have? Symptoms and signs. So they can give you history of negative symptoms. Negative symptoms are the ones where there is loss of certain sensation. So if when I see a patient or when I examine the patient, the utmost try that I have is to define the underlying loss in a peripheral nervous system to small or large fiber modalities or both. Right? So vibration, joint position sensation is probably more affected in my patient group right now with chemo-induced neuropathy. And then in some people who have a neuronopathy, where they have dorsal loop ganglion affected only, they don't have the length-dependent loss of pinprick. So when you do the examination, the pinprick is actually quite normal because it's diffusely reduced. Sometimes I see only vibration reduced, and other times two-point discrimination is a factor. But there is exposure to the platinum drugs, and it gives me a guideline to look for this. But in any case, when you see a patient, what is this stick here? Somebody's trying to correct my spelling. So negative symptoms are when there's loss. Positive symptoms are the one where there's gain of a new function, new extra functionality in sensory or motor. So this is challenge. Okay, so the positive symptoms are when there's tingling, the pins and needle sensation, prickling, lengthening pain, aching, knife. So these are the descriptors you'll hear from patients. Negative are one where they will describe more of numbness. There's loss of that sensation. There's deafness or feeling of wearing socks in patients with neuropathy. In case of motor symptoms, motor neuropathy, because that's something we have to look at as well, cramping is a positive symptom. The weakness is negative symptom. Symptoms can be spontaneous or evoked. They could be persistent burning or pain, or it could be intermittent where you can feel shock-like feeling or lancinating pain. What's going on there? I'm not doing it, so it's still going on with the next slide. Is that a pop-up? No. It just keeps going. Okay. And then what do we do in exam? What do we need to look at? Negative symptoms will go with the examination that would show loss. So you'll see numbness or hypoesthesia, reduction in pinprick, vibration of joint position sensation. And the positive you can evoke by eliciting allodynia, whether it's thermal or mechanical. You can, I'm not doing it and it keeps going.
Maybe after you change slide, just take it off the button in case there's something that's
on
your machine.
Oh, okay. Maybe it's just picking motion. So in examination, and one of the things we don't do in Canada is we do not do QSTs. And there may be some future direction where testing for hyperalgesia, I'm not even close by, hyperalgesia. Oh, God.
Is it possible you have a voice recognition software running that's trying to take commands from you, maybe? And like, I'm seeing that little thing in the middle.
Yeah, I have something here. Dragon is there. Let me just close it out.
Is it Cortana or something, maybe?
No. But it's not.
Just try closing any applications that might be controlling your computer.
I was at them. Oh, I was blaming it on you. Could have gone with it. Where did it go though? Where's my top gun?
WebEx. It's the bottom icon on the right there. It's one that looks like a little beach ball.
This one?
A white and green.
Oh, this one down here. Okay.
Perfect.
Sorry about that. I think you've seen it enough times so I can skip my Okay. So when we see a patient with neuropathic pain, you have to take the pain history, starting with the onset and duration and location, distribution, quality. So regular history. I always tell my students, keep headache history as your primary guide when you're taking pain history, because in headache you're looking at somebody when they're normal. You're also looking for onset, whether acute or not. You're looking for different phases, right? So it kind of, you don't miss details. You ask for the location and you see what makes it worse. And so those principles, if somebody can stick with them, you don't miss a lot of details. But what's important in patients when we are assessing in any chronic pain, let alone the neuropathic part, is the presence of comorbidities. Because if you do not address them in somebody in chronic pain, there is absolutely no magic pill out there. The ones that we'll be talking about a little bit, the number needed to treat for a lot of them are deplorable. If you look at the main drugs that we have, 7 NMT, is it acceptable? Not to me. But then we're missing a boat. So there are things that we will miss completely if we don't address them. And in this today's culture and where things have been with pharmacotherapy, especially with opioids, if you do not, at the word go, do not assess the risks of addiction, you will run into problems. So that should be part of your first evaluation, especially at the second year tertiary level. Family doctors, we're hoping are able, they have a better understanding of their own patients. But you have to look at the risks and comorbidities as part of your initial evaluation. And then you look at treatments that have been offered. And this I'm basing on what we see here in the pain clinic or in our clinics, specialty clinics. and what treatments were offered and what their response was and what the appropriate trials. Now, once you see a patient and you are not sure, is it neuropathic pain, is it a combination, is it nociceptive only, then there are some other scales you could use that will help you in deciphering whether you're dealing with the neuropathic pain. So you can, with the Leeds questionnaire, assessment of neuropathic symptoms and signs, 7-item questionnaire, more than 12 score is suggestive of neuropathic pain. With DN4, 4 or more, is suggestive of neuropathic pain. With pain detective, the score is 18 or more out of 38 scale when you're dealing with neuropathic pain. So some of these are just purely questionnaire. Other ones are also involve putting the characteristics of the neuropathic pain as well as the examination. And I'm going to keep skipping through them quickly. When we talk about the comorbid conditions, about 50% of the patients have either psychiatric or sleep disturbance or both. So depression, anxiety is common. Depression, depending on which studies you look at, is between 20 to 71%. And people who have depression, at the time of the diagnosis of their depression, without any previous history of known pain-related problems, they report of having pain. So it goes hand in hand. And then when somebody has significant disability from pain, then the adjustment disorders that can play in, and that can set the cycle for poor response. Then you have the clinical tools that most of the ones I mentioned here are for addiction risks, and none of them charge you if you use their scales. So these are web-based scales you can use for assessing opioid risk, opioid addiction risks. And that I will leave it with you guys because luckily what I do, I don't do a lot of opioid prescription anymore. It feels really good. So when you examine a patient, it should be detailed MSK as well as neurological examination. Now, you deal with enough patients with neuropathic pain that almost always you'll see when you're dealing beyond a certain range, when the concepts of sensitization have played in with the peripheral and central. And again, these are very crude approaches. I don't think we know exactly what goes on. They have myofascial component, and their examination, MSK examination, will be abnormal. So, and sometimes the other way around. If we give you the commonest neuropathic symptom, if anybody knows, in patient with lateral epicondylitis is what? So tennis elbow, probably in a chronic tennis elbow patient, more than 1/3 have dysesthesia, burning pain in the dorsal aspect of the forearm. And that happens because the dorsal cutaneous nerve of the forearm that's sitting right next to it, when you do ultrasounds, it's almost always affected to some degree. And so in those cases, if you target the lateral epicondylis, the extensor carpaldialis brevis with injection, you may just go a little bit higher to try injecting that one. It will help more. Or you can do radiofrequency if that's available as an option. But all I'm saying that you have to do detailed both MSK and neurological examination. The neurological examination, especially the sensory examination, should look for both small and large abnormalities. In case you find someone who comes with a distal length-dependent type of a neuropathy, and you do pinprick, and they're up to mid-shin, and you investigate them. EMG is normal, their ankle jerk is preserved, and you're going to start thinking, yeah, totally thinking it. Maybe read it on Google or something, and that's why it's. But the test of choice there is skin biopsy. That will prove that they have small fiber neuropathy. And the EMG is almost always normal because EMG is looking at the large fibers, the myelinated fibers only. And when that modality is not affected, the test is not going to pick that abnormality. Then when we're dealing with radiculopathy, mononeuropathy, plexopathy, there will be concrete deficits in the sensory and motor examination, and that's what you want to establish. A simple thing, if somebody, somehow, I'm like a magnet for physicians who develop brachial plexitis. So I was rounding 6:30, somebody said, so he showed me, I think I have ulnar problem, but my shoulder is hurting like crazy. So I did the exam, just, pinprick. Sensory deficits going into the forearm. The ulnar nerve never goes above the proximal wrist crease, and that was the only clue to getting an MRI and picking up the brachial plexitis. But all I'm saying is that your examination will guide you if it is a certain asymmetric, say mononeuropathy, radiculopathy. You should have those sensory and motor deficits, and your deep tendon reflexes, if they're in an appropriate way affected, it should be affected. And they guide you better with your investigation, the pace of investigation. Are you going to get them urgently? Are you going to wait for another 3 to 6 months? And it will help you with the rest of the, say if you want to do an EMG. By the way, EMG, the only thing I would recommend, but obviously pain clinic patients are not the ones we get. If somebody has acute injury, wait for a few weeks, because EMG will be normal, even if the nerve is cut, because the nerve connection studies will start to get affected by day 6 to about 10. Before that, the nerve connection studies will not take anything, and needle examination takes about 3 weeks or so, 3 to 4 weeks to become abnormal. So it's not very diagnostic then. So in chronic, and that's where the MRIs on urgent basis would be more important if you're looking at more central, closer to say radiculopathy picture. And if you're looking at a peripheral nerve, ultrasounds nowadays are quite good. If you can get to it soon, that will be probably a better choice testing for you. So I'll keep going. Oh, come on. So if somebody has the history and physical examination diagnostic, and further diagnostic tests are positive for a concrete diagnosis you're looking for, they fulfill all the criteria, history, physical, and investigations, and they have definite neuropathic pain. If it is A only, then it's possible. If it is A and B or C, 2 of them are positive, then you're dealing with probable neuropathic pain. So this is EFNS classification for possible and probable and definite neuropathic pain. I think we need to go beyond it. We need to make a concrete diagnosis rather than looking for that. Now, you find a neuropathy or other specific diagnosis if you can treat them by addressing the underlying disease process. You have to offer that treatment. So if somebody is B12 deficient, start doing with B12 replacement. Symptoms may or may not improve, but at least the disease is not progressing. If somebody has a carpal tunnel causing thing, you can try conservative measures or go ahead with the decompression surgery, or if there's another entrapment neuropathy. If somebody has AIDP or CIDP or other diseases that are causing demyelinating neuropathy that will respond to immunosuppression, you can start off with IVIG. So targeting that underlying disease process. When it comes to managing the pain, and most of the patients that you see, the approach would be more multidisciplinary, multimodal, and addressing not only the pain and the actual diagnosis then, you're also then looking at the comorbid conditions. Sleep, commonly affected. Depression is common. So addressing that and having those resources, if you're not able to give them, that those resources available to patients would go a long way. And then you have the neuropathic pain-specific pharmacotherapy. So I was involved in this original 2007 guidelines from Canadian Pain Society. So what did it did not go by diagnosis. It went by you have a chronic neuropathic pain, how do you treat it? You had first-line treatment, which were TCAs or gabapentinoid drugs, and second line was SNRIs and topical lidocaine, and then you were looking at painkillers as tramadol and modified release opioids, and then the fourth line was really your back is against the wall and throw anything and everything that's in the realm of safety on patient. So then there was a device, one in 2014, which just brought the SNRIs up to the first level as first-line drug. So in the SNRI, the addition is actually venlafaxine on top of duloxetine, and then you have the tramadol and opioid analgesics. Cannabinoids, to me, in my practice, I would say people are a lot more willing and open and wanting the cannabinoids before they try any opioids. And that those requests are, discussion is much more easier now than it was before. In here, no patients. My patients are elderly, a lot of them, and the few years back, the acceptance of the cannabinoid-based approach was not there. So now that's not the case. And there are some good clinics and some maybe not so good clinics. I don't prescribe them those, but there are clinics who look after it and they look at the ratios and different aspects of it. And so that's one thing that's taken away from you, which is good. Now, when we look at European Federation of Neurological Societies, they came up with the individual diagnosis. So individual diagnosis, pain for peripheral neuropathy, they divided into level A, B, C on basis of evidence, and then they went with first line and second line recommendations. And first line with that is duloxetine, gabapentin, pregabalin, tricyclic, and venlafaxine ER. And then second line recommendation is opioid and tramadol. Post-herpetic neuralgia, capsaicin 8%, and gabapentin. Then you have the opioid, pregabalin, tricyclic, and lidocaine plaster, or in US it's a lidocaine patch, is the level A. But capsaicin is not part of the first line treatment, at least as per their recommendation. They go with, again, same medication, gabapentin, pregabalin, and tricyclics. They did not find that there was good enough evidence for the SNRIs to recommend in post-herpetic neuralgia. In case of trigeminal neuralgia, which is a completely different, and I did not go into the pathophysiology. This is a pure sodium channel disease, and it only responds to sodium channel blockers as, even Dilantin response is quite good. I use Dilantin when somebody is admitted and not able to take anything in. Dilantin IV does the trick, at least when they're able to swallow, they can then go back to the carbamazepine or trilaptol. So they are interchangeable, and then if that fails, you go to surgery. And then you have a central neuropathic pain. Pregabalin and cannabinoids have good evidence, at least at that time, but cannabinoids were not recommended as first line. I think at this point, in most of the North American centers, that is probably first line in MS patients. So first line there is same, TCA, gabapentin, pregabalin, and then cannabinoids and the motragine and opioids as second line. Then this is the one that most of my colleagues in the U.S. follow. This is from 2015 we did the big review of the evidence available. And based on that, based on the level of evidence, quality of evidence, tricyclic antidepressant, pregabalin, gabapentin, they have gabapentin extended release response in the U.S. They are the first line treatment, and then you have the second line with moderate quality of evidence and the effectiveness that goes into, so the SNRI tricyclics and gabapentinoids are first line. The second lines are tramadol, capsaicin, lidocaine, and then third line are botulinum toxin and other stronger opioids. So this is where medications work. And I, again, because of time and because I have too many slides here, I didn't want to talk a lot about the pathophysiology. The medication that we use, so if you have to imagine pain signals starting in the periphery, going to the spinal cord, going all the way, going contralaterally to the cortex, and then you have the descending inhibitory pathways. So the medication that we use, they are either working peripherally, so these are the medications that are predominantly sodium channel blockers, or you can have more at the spinal cord level, which are generally calcium channel modifier, and NMD works on NMDA, and then you have the inhibitory pathways, which are the other drugs that we use. Some have multiple areas of impact, but these are the three main areas, medication that we use to target. So what is the body of evidence? So these are different medications with the meta-analysis looking at amitriptyline. The NMT is probably the best among the anti-neuropathic pain agents for amitriptyline or Elavil, but number needed to harm is also the highest. And then if you look at some of the U.S. recommendations, they do not recommend amitriptyline in people older than 65 because of the cardiac side effects. Again, lower dosage, we almost always use it. In the older recommendation, when I was practicing there, anytime you're anticipating dosage of the tricyclics to go above 100 milligrams, you have to get a baseline EKG and then get it once you get to that level. So that's probably the best number needed to treat for any of the drugs. For pregabalin and gabapentin, that's where at 7.2 and 7.7. Number needed to harm is in its favor compared to amitriptyline, but this is not really, this is what we have to give. So when we are seeing a patient with chronic neuropathic pain, one thing we have to work on, if we're going to work on our relation, is to have the realistic expectations from ourselves when we're providing the care, and from patients from their expectation. So that's our one of the main group of medication we rely on. They're safer drugs. They're not interacting, and in my patient groups, when a lot of the chemo agents are going through liver, they're probably the best ones available. But I do like to have that discussion that it may or may not work, and this is why. Then you're looking at so some of the trials were actually, initial trials were that the drug companies showed were about 4.8. But if you look at the cumulative data, that's quite big, 7 plus. The duloxetine and venlafaxine is about 6.4 number needed to treat. That's what you're looking at. And then you have the opioids. And again, here, you have to take it, when we start looking at just the numbers and not looking at individual drug or individual patient, this is what we get. Pretty good number. But look at the challenge that you'll have. And somebody who's going to have maybe lifelong pain. what it's going to do. These are trials between 8 weeks and 12 weeks, looking at effectiveness. And so these numbers may not be reflective of what we end up dealing with the patient, but that's where the data is. So these are the medications that were ineffective. So for painful polyneuropathy, castration cream, oxcarbazepine, SSRIs, lacosamide, the list is quite long. For postoperative neuralgia, again, pretty long list, including our second-line agents here, and then the central neuropathic pain. So what do you do with patients when we talk about individual diagnosis? Say you have somebody with mononeuritis or mononeuropathy, where only one nerve is, say you're dealing with entrapment neuropathy, like carpal tunnel. So let's just pass this step. In that case, you try to give them individual treatment. I don't want to start another topic there, that's why I skip through it. So in case of neuropathy, along with the medication, you do want to emphasize the importance of foot care. I usually tell patients to buy a little mirror, put it next to their couch, and when they sit there in the evening, pick it up and look around like this. See if there's anything of concern, any redness, anything between the toes, because otherwise, when somebody has neuropathy, you're likely in older age group, you may be overweight, and it may not be that convenient to look at it physically. By just moving the mirror around is usually helpful. Padded socks, appropriate shoes, and inspection, as well as care with exposure to any heat injury and keeping the dryness at bay. So these are general part. I'll keep going. So when you get into specific diagnosis, the management, when you look at central neuropathic pain, the main medications for post-stroke central neuropathic pain, spinal cord injury-related central neuropathic pain, and MS-related central neuropathic pain, the evidence is lacking. Most of the trials show the common drugs are not that effective. The positive trials have been with pregabalin in the spinal cord injury patients and cannabinoids in MS patients. The rest of it is not really that convincing. Post-stroke, only 2 relatively positive 2 to 3 trials with amitriptyline and lamotrigine, and there was one of the initial trials with pregabalin was positive, subsequent trials were negative. In case of radiculopathy, it is not well studied. Controlled trials are relatively few and far in between. The level of evidence for effectiveness of medication for radiculopathy in trials is not convincing at all. Trials for morphine, nortriptyline, topiramate, pregabalin, they were all negative. If you look at the trial part, again, it's very hard to randomize when you're doing the epidurals and those. Personally, my feeling is that if you're able to get to interventional pain specialist as soon as possible, it's probably best. And I have an advantage where I'm seeing them in EMG, and I'm looking for whether there's any axonal involvement or not. And if there isn't any, I would like them, and I hope they can see people soon. But sometimes it's just a hope because the waiting period is, not as bad as a few years ago, but it's still not that great. Post-surgical, only level B evidence for amitriptyline and Botox, and majority of the other medications in all the trials were ineffective. In case of multi-etiology neuropathic pain, again, the level A evidence is for cannabinoids and levorphanol and the antidepressants. Methadone and tricyclic antidepressants were level B. and then a huge list of ineffective drugs from all those trials. Okay, so what are we to do? So I'll probably skip through because of time, some of these slides. So when we're starting these medications, it's always good practice to start with a low dose and gradually increase the dosing. If you find a drug which is ineffective, it's better to take that drug out. So it creates more room for you to try another drug. If it is partially effective, then you can combine with another medication if it is safe to combine. And there are few combinations that we don't want to do because of the risks involved. Why do people fail? Because the medication, you saw the level of evidence, is not that great. Sometimes the dosage that's given is not enough. Other times the duration of the medication is not long enough. And yet again, those associated problems that we see consistently in chronic pain, including neuropathic pain, are not well addressed. So we end up dealing with poor response to our management. In other cases, we've done all that, and we still know. I finished my fellowship 2003-04 in pain, and I always felt it's like you're not really helping because there's something missing, and something big is missing. And I think that if you look at some of the newer data, it may be giving us a bit of a direction. So if you look at oxcarbazepine, the trilactol, which is sister drug of carbamazepine, we use it in patients with trigeminal neuralgia as first-line treatment. So what they did is they did stratification of the patients for trial. The trials have been failure. All the trials, because carbamazepine had, if you look at maybe 46 to 50 years old trials for pain, neuropathic pain, it was effective. Recently, it has not been well studied, so it's never made into our recommendations. But if you look at older physicians, my teachers or my older colleagues, they still start with carbamazepine as maybe the first-line treatment. But there is some truth to it. But trilactol showed no response. There was no statistically significant improvement in any of the central neuropathic pain trials. So what they did with this trial is on the basis of QST, the quantitative sensory testing, they divided patients with sensory loss to thermal hyperalgesia. Because you have a graded increase in the intensity that you're testing for something. So people who had the thermal hyperalgesia, you can see the number needed to treat, 3.9 compared to 13. So there may be some role to stratifying patients' symptoms and signs to help you guide with certain treatment. And that may be coming. Now, if you look at data for neuropathic pain in cases of Botox, I remember first time when I used it was 2002. I was in my fellowship. I had a patient who was getting for headache, but she had also trigeminal neuropathy. So I used intradermal. And I was encouraged to use it because we were using Botox for pelvic regional pain syndrome, where we were injecting into subcutaneous tissue in groin, and people were reporting improvement. So that was, I presented that I think in 2003 or something. In any case, but I could not reproduce it. Other patients say they had post-herpetic or other localized area of pain, post-surgical neuralgia. I could not reproduce in each patient. Some responded, some did not, and the characteristics I could not define on basis of just examining or history. So here, people who had hyperalgesia on QST, they responded quite well to intradermal Botox compared to the ones who did not. So that may be the direction we may end up going. Then the polypharmacy is other something that we may safely do, and a rationalized polypharmacy may be better in some cases of patients. So some of the trials do show that combining medication from different groups may be better than higher dosage of individual drug. Say in case of pregabalin and imipramine combination for neuropathic pain was better than placebo or pregabalin or imipramine alone. Similarly, the other trials looked at the nortriptyline and gabapentin and found that it was better than the individual drug, even higher dosage. So there are few. I think we were started off by Gilron, the anesthesiologist. And is he still in Kingston? Or? Yes, he's still there. So that was the initial actual formal trial, and since then there have been many, and it shows that combination is better. And then there was another trial for patients in some cases with post-hepatic neuralgia, and also in painful diabetic neuropathy when pain is localized to distal feet, where you're not spreading the medication around. Botox trials have been positive. And again, these trials do not mention thermal hyperalgesia or not. So Joe is getting restless. The other thing we do here is the couple of things I do, and I try alpha-lipoic acid in some of the patients with chemo-induced neuropathy. So meta-analysis of 1,200 plus patients with diabetic neuropathy, they found that with use of alpha-lipoic acid, which is an antioxidant, that there is improvement in symptoms, but there is also in one trial, there was regrowth of the fibers on the biopsies. And in some trials, there was improvement in the electrophysiological parameters, suggesting some degree of reversibility in diabetic neuropathy in these patients. And that's not a painkiller. It does not affect the pain itself, but that may be something we need to do in patients with diabetic neuropathy. Acetyl L-carnitine had positive neuropathy trials as well. And then these are, so a lot of the slides I think you guys will get, so I did not go into a bit more, more details. So these are the dosage. So when, in summary, when you have the neuropathic pain, it is coming from pathology of the somatosensory nervous system, and there is a lesion in the central or peripheral nervous system. Pain that comes from neuropathic sources is specific characteristics, and there may be different sources of it. Pathophysiology of neuropathic pain is not uniform. It depends on underlying pathology, and if my hope is that if we can look into maybe future there are things that will individualize a patient on basis of, say, thermal hyperalgesia or some other measures that will stratify a patient into this group that may respond better to sodium channels versus the other form of medication. But that's something in the future. But here we end up doing personalization on day-to-day basis. Patients that I see with, say, platinum-induced neuropathy, they're not all the same. And if we are seeking out underlying pathology, if you're seeking out how you're going to approach the dosing of certain medication, because in first or two visits, one or two visits, you'll find out that this person, I cannot jump from 75 and 75. You may have to go 25, 25, increase in Lyrica or 10 milligram increment on TCH. So those are the things that we have to constantly work on. And sometimes, I wonder, this patient's been coming to me for so long. What have I done? And last Tuesday, I had the same question from a fellow. And we went in, and we asked her, visit before, to just increase the amitriptyline by 5 milligrams only. And that makes substantial change. So if you keep at it, and if you keep individualizing your approach to managing those patients, without that knowledge that may come in future to us or our kids, I think you will still make a difference in their care. I'll leave it there.
Well, thank you very much for excellent. For me, it's a good review for neuropathic pain. For me, not all neuropathic pain is same. So yes, reasons why. So anyhow, we're gonna open to questions. If you have any questions, Ali. And also we have if people from WebEx have a question, you will have a chance to ask questions.
For people who have questions live, please repeat the question or paraphrase for the
So Ali.
Okay, thank you for the presentation. It's really good. But I have a question. You told us if you add a medication for neuropathic pain and it doesn't work, it's a good idea to stop it and add another thing. How long do you say it's reasonable to decide if it's helpful or not?
So that
Can you repeat the question?
So the question is how long do you wait before you declare medication to be ineffective, right? And then take it out and maybe replace it with something else. And again, that varies medication to medication. If we are dealing with the older form, the older formula was, okay, you titrate it to the maximum tolerated dose, which is within the allowed parameters, and give up to 12 weeks at that. That was true for TCAs, and that was true conventional for the gabapentin. So those were the main ones we waited for 12 weeks. Now with the newer ones, from experience, I can say that, say you reach a dose of pregabalin that's well tolerated, or say you hit the maximum mark of 600. Generally, in my experience, majority of the average size patient, if 450 is not cutting it, 600 is not going to do it. But that's your individual experience. But if you get to the maximum dose and no side effects, I'll wait about 4 to 6 weeks maximum. In case of Cymbalta, maybe not even 4 weeks, because they tend to kick in quicker than the older drugs. But otherwise, the fair trial is where you reach the maximum tolerated or maximum dose, and if it's not effective, then you look at alternatives. One of the things that, as rule, is good is to keep things steady. Unless you're combining two drugs that can harm patients, keep everything the same when you're introducing a new medication. Other thing that we frequently see, all of us see, is that when we're cutting the medication down, patient will come to you, say they're on 12 weeks for a medication, they come to you, they tell you, I did absolutely nothing. My pain was 7 or 8, and it's still 7 or 8. And then they start cutting it down. And then they go, it went to 12, right? So it is doing something then. In that case, doing a slow titration down is also helpful. You can just, some medication we can't stop them abruptly. Say somebody's on TCAs for long, yeah, their life will be miserable. If the tachycardia and the stuff that doesn't bug them, they won't be able to sleep for days. Right? So,
Chris, is there any questions from WebEx people? No? Okay, go ahead. Yeah, go ahead.
You covered mainly pharmacological therapy here. Where does pulsating a radiofrequency ablation come in with regards to neuropathic pain?
Where I use it, and I'm talking from my personal experience, if you go European countries, they have a separate recommendations, which includes even the transcranial magnetic stimulation to your spinal cord stimulation to deep brain stimulation, and then you're looking at the RF. Here, mononeuropathies, and preferably field sensory mononeuropathies, are first choice. In my patients, say somebody gets lateral femoral cutaneous nerve, neuralgia peristatica, I nowadays I don't hit for nerve blocks. I send them for ultrasound guided RF. I have tried few patients even headaches for RF. If you have, say, simple V1, which is related to a neuropathy, not I'm talking about neuralgia. That's where I head up to. I've had 2 patients. I don't like to give a lot of these supraorbital nerve blocks and stuff. They have greater occipital nerve due to RF. But some people are extending it to motor. I don't have much experience. So if it is a pure sensory nerve and pure sensory symptoms, then yes, I would say I'm not talking about the evidence. And if it is my patient and if it is in realm of safety, I would prefer them coming up sooner than later.
Thank you. Okay, it's now 6:31 now. So we'll take one more question.
There's one question by the solution guidelines for the neuropathic pain. In your experience, what you use is, for example, if you have covered the first line, the patients are now, as you mentioned, also open for the use of cannabinoids. So will you switch over from stage 1 to stage 3 with cannabinoids, or there's a room for opioids?
So the question is that there is more acceptance of cannabinoids now than before, and it may be the patient wants to try that as first line rather than third line treatment. Personally, I would still like to keep it closer to. I would try maybe before I go to opioids, maybe after tramadol, personally. But I tend to see a lot of people who are already on it without trying any anti-neuropathic pain agent. And the issue then is, okay, you didn't start it. And by the way, that if you can take anything home, forget about all the guidelines, because you're in a tertiary care setting. You have to individualize treatment, right? So here, say somebody's on it, and it is working for them, right? You establish, you do a diagnosis, make sure it's not some other reason they're taking it. Now, then that's the dilemma, that this is not the normal approach to managing it, right? I personally would not take them out if it is working. If it isn't, then you're going to preferably take it out and start it at level 1 and go down that way.
Okay, thank you. Thank you very much for your excellent